Good afternoon, everyone. I hope I'm audible. Good afternoon.
Yes, ma'am.
Good afternoon, everyone. On behalf of Indian Academy of Oral Medicine and Radiology, Karnataka branch, and as a member of CDE committee, I, Dr. Shilpa PS, reader from the Department of Oral Medicine and Radiology, welcome you all for today's CDE program. This is the first CDE program held under the authority of IAOMR Karnataka branch, and there will be many more to come. I would like to convey a hearty welcome to Dr. Chaya M. David, Professor and Head of the Department of Oral Medicine and Radiology, Dayananda Sagar Dental College, and also the President of IAOMR Karnataka branch, and Dr. Ramamurthy TK, Professor and Head of Department of Oral Medicine and Radiology, Vaidehi Dental College, and also Honorary Secretary for today's CDE event. I would like to extend a warm welcome to Dr. Hemant, Principal of Dayananda Sagar Dental College for today's CDE event. Dr. Ravikiran Ongloe, Professor, Department of Oral Medicine and Radiology, Manipal Institute of Dental Sciences, Mangalore, is with us today to enlighten our colleagues and students. I would like to welcome you to today's program. A warm welcome to my fellow CDE members, Dr. Shruti, Dr. Sanjay, Dr. Kirti, Dr. Preeti Patil, who helped me in organizing this CDE event. Finally, I would like to extend a warm welcome to all the HODs, professors, associate and assistant professors, senior lecturers, PG students, interns, and undergraduate students attending today's event. I'm very happy to say that we have received more than 300 registrations for this event. I'm hoping this event initiative will be successful. Now I request Dr. Ramurthy sir to address colleagues and students. Thank you. Over to Dr. Ramurthy sir.
Thank you, Shilpa. My video I'm not able to see. I think they disabled my video.
So you can on your video, sir, now.
Yeah, madam, I am now. Yeah. Good afternoon, everybody. I can see Dr. Hemant's face, Principal of Dayananda Hemant for this program, and also Karnataka IAOMR branch with Dr. Chaya David, madam. I thankful to Dr. Hemant and Dr. Ravikiran Ongloe, today's speaker. I know him well since Ambedkar days. I thank Dr. Ravikiran Ongloe to accepting the invitation and today you are the part of speaker today for this our CD program. And I would like to thank Dr. Chaya David, madam, is president of IAOMR Karnataka State Branch. Madam is a very keen interest to organize this event today in association with Dayananda Dental College as well as Karnataka State IAOMR branch. And also I would like to thank CD Chairman Dr. Shilpa. She's a keen worker behind this to take up this program, especially to organize this brochure and to communicate with the speaker as well as his taken keen interest. I would like to thank Dr. Shilpa to organize this program. And also I welcome all the participants for this program. This is very much beginning program. Future many programs we're going to organize. I request you to all participate. Our state conference also going to held at Dayananda Dental College in coming probably month of September. Dates are confirmed. So I welcome you all and all the best. I hope you're going to be rich in knowledge with this today's scientific program. Thank you, Ananda. Thank you.
Thank you very much, sir, for your encouraging words. I now request Dr. Hemant M, Principal, Dayananda Sagar College of Dental Sciences, to say a few words.
To all, teacher Dr. Chaya ma'am, Dr. Ramurthy sir, today's eminent speaker Dr. Ravikiran, and first and foremost, a very important topic is today's webinar, that is potentially malignant disorders. There is no doubt, very important topic that we are facing, that to 3% of cancer patients accounts to the oral cancers, and every student and every staff definitely needs to be educated on these topics. First and foremost, I thank Ravikiran for accepting our invitation and being with us. The second most important is, as I told, we should all update to protect our own patients who are potentially malignant, which can turn into the cancer. These are the programs and these are the topics which is in need of the hour. And I'm sure the Karnataka State Branch, with the heads of my teacher Chaya ma'am and Ramurthy sir, will definitely make sure this education keeps going on and everyone are updated, and we all ultimately, as a noble profession, we need to serve the society. So with these few words, I thank OMR department and Karnataka State Branch for giving me an opportunity to speak few words, as Dr. Ravi is fully geared up to give his talk, and I wish all the participants to have an enlightening program. Thank you, ma'am. Thank you, sir.
Thank you very much, sir. It is my pleasure to introduce our guest speaker for today, Dr. Ravikiran Ongloe, sir. Dr. Ravikiran Ongloe earned his master's degree in specialty of oral medicine and radiology from Manipal University in the year 2002. Ever since, sir has been pursuing his passion for teaching. He was recipient of Good Teacher Award in 2012. Sir has authored 2 books in oral medicine and radiology and is on the advisory board for the first South Asian edition of the Textbook of Oral Radiology, edited by White and Furrow. He has been invited to speak at various CME, CD programs and international conferences. Dr. Ongloe was a symposium speaker at the International Association of Dental Research and American Association of Research meeting at Boston in 2015. Sir was keynote speaker at the Royal College of Surgeons in Ireland in 2016. Apart from his passion and interest in teaching, he is actively involved in funded international collaborative research projects dealing with prevention, detection, and medical management of oral precancers. He has filed 3 patents and has won various innovation awards. At the university, Dr. Ravikiran is a staff mentor for the Student Research Forum, member of Scientific and Ethics Committee, and also the coordinator for Innovative Center. Dr. Ongloe is currently serving as professor and head and PhD guide at Manipal College of Dental Sciences, Bangalore. Sir, we are very happy to have you with us, and I now request you to kindly take over.
Hope I'm audible.
Yes, sir. Yes, sir.
Yeah. Thank you so much for that very kind introduction. At the outset, I'd like to thank the principal of Dayananda Sagar College, also the Karnataka State IAOMR branch for having me here, especially Dr. Chaya David ma'am. She's such a senior person. We all respect her in the fields of oral medicine and radiology. Thank you so much, ma'am, for inviting me over to share my few thoughts on potentially malignant disorders.
Excuse me, sir. So your voice is very feeble.
How about now? Can you hear me? Is that better?
Sir, it is still the same.
Oh, really? Is it better now?
Yes, sir. Yes, sir.
Is it better or still?
Sir, it is better, but it is
Can you
still a bit
confirm
feeble.
it's better now?
Yes, sir. Yes, sir.
Can you confirm it's better now? Yeah, it's much audible better now. Thank you so much. So sorry for that glitch. This happens with these online programs. Okay, so at the outset, I really profusely thank the principal of Dayananda Sagar College, also Dr. Chaya David ma'am, for having me here, President of the State Karnataka IAOMR branch, also Dr. Ramurthy, the secretary. Thank you so much, sir. Like sir was just mentioning, I learned from the Ambedkar Times. He was my senior there. I'm also so glad to see a galaxy of participants, I should say, because when I spoke to Chaya David ma'am, she was, I checked with her who were the participants. She said she probably started with, I think she said undergraduate students, then she said postgraduates, then she said maybe practitioners, and then she said faculty. So literally, I get to see everybody here today. So thank you all for sharing your valuable time with me here today. If I may, I can indulge in a light-hearted note. Over the last 1.5 2 years, a couple of times, ma'am got in touch with me, Dr. Chai David. I used to see a couple of messages on my WhatsApp, and then that actually had tones of, should I say, discussion on curriculum and very high-ended academic things that ma'am had vision for. I somehow felt she was not, it wasn't for me. So I politely wrote back saying, ma'am, I think I'm not the Ravikiran you wanted to talk to, I guess. So she was in fact trying to get in touch with Dr. Ravikiran, who's in Siba from IAOMR. And then recently, a week back, when she contacted me saying, would you want to speak? I was really wondering if it was me again or it was somebody else. I wasn't sure if I was to speak until I sent my picture and my resume yesterday. So since she took it and said thank you, I knew it was probably me. So I'm so glad to be here today discussing something on potentially malignant disorders. So the next 45 minutes to an hour or so, Monday afternoon, let's look at we'll move to, I think, a few basics and some updates. And also, I think I'll add a few, I rather did add a few topics that are, should I say, research related that we have been doing at Manipal University, especially in collaboration with a couple of other departments in the fields of oral precancer. So I think we can carry home some messages today. So with that small introduction from my side, I'll share my screen and please let me know if you can see it, and then we'll go forward. Hope that's visible, right? And you can see my screen. Is that full screen or you just see a part of it? Is that full now? Yeah, is that a whole screen?
Sir,
Now?
we can't see it as a full screen.
Yes, now you should be. Now? Is that full screen
Sir,
now?
no, sir, it's not yet in the slideshow.
Not yet. Okay. I'll try one more time.
Yes.
Okay, close that.
So it is still not yet in the slideshow.
Oh, is it? Okay, because that's what it shows me. Okay, one more attempt. Do let me know if it's in slideshow. I'll make one more attempt. Yes, how about now? How about now?
No, sir, it is still the same.
Oh, really? Okay. I don't know what to do. Should I just go ahead? Is it okay?
Yes, sir. Yes, sir.
It's too bad. It's okay now. It's okay, right? I'm actually the screen is paused. Okay. One more time now. How about now? How about now? Can you please
Sir,
confirm?
it is still the same, sir.
Should I just go ahead? It's okay.
Yes, sir. Yes, sir.
Yeah, just go ahead, I guess, right? Okay. So I don't know how to get out of it, but anyway, let's I think let's go ahead if it's not a big problem. Is it okay, right? Yeah, it's okay. Can you please
Yes, sir.
confirm?
Yes, sir. We can see the slides clearly.
Thank you so much. So warm greetings to you. I'm like just mentioned, I'm from Manipal University. I work in Mangalore. So what we're going to look at today is oral potentially malignant disorders. I should just say by default or just so happened that coincidentally a couple of days ago I had a rapid review program in Sri Ramachandra is also discussing the same topic there. Some postgraduates who did attend the talk, don't worry too much. They are in the same exact slides. There's something more to take home today. If you did not attend, then probably for the postgraduates, there's a little more update here for you. So initially, I think what we could all look at is some kind of clarity is what we need to understand. The clarity that we are going to look at here is so studying point of time when I was in dental school, we all heard of these terminologies, right? And over the years, these terminologies have changed. What was initially taught in the dental schools in the year, I should say 95, 96, all that time, was on two popular terminologies rather, precancerous lesions and conditions. And when somebody said precancerous lesion, all we had to understand was it's some kind of a morphologically altered tissue in which cancer is more likely to occur when compared with its apparently normal counterpart. So what they're trying to define here is, so it needs to be morphologically altered as in when you clinically see, you need to visibly see a change. And then that change has to be compared with what? Probably if you see a morphologically altered right side buccal mucosa, you want to look at the left side and say, okay, fine. Now when I compare, there's some kind of alteration. So this kind of change was what people looked at when they said precancerous lesion. And the term precancerous condition was used when it was more to do with a generalized state. Now this was a small gray area for many of us because when you talk of generalized state, the debate is it generalized state of the mouth, is it multiple sites, or is it generalized state of the body, but predisposing to a patient or to an individual who might now soon see an increased risk for cancer. So that generalized state was associated, I think, both with a generalized involvement, not just a local patch, a generalized involvement plus some amount of systemic debilitation. So that was precancerous condition. Things are all easy at those point of times. In 2005, a new term was used. And for many of us who finished our MBS much before that, this term was something new we all kept to hear. And over the last decade or so, this is the most popular term that is used. Nobody uses precancerous lesions or conditions anymore. They use something called oral potentially malignant disorders. Now this term was given in 2005. Here what it's saying is they've combined both the lesion and condition together of the oral mucosa. So it could be a lesion, it could be a whole condition of the mucosa that has potential for a malignant transformation. That is a very simple definition proposed there. Over time, roughly around 2000, I should say 12, 14, the time, majority of the faculty would know, postgraduates should know that Dr. Christian Scully and his team were doing a lot of work on oral cancer. Rosker was also another person who was working on a lot of oral cancers, or rather is working on oral cancers. But since after Dr. Scully's passing, a lot of work now has been done by Saman Varnakulasuriya. If you actually look at literature, you see Saman Varnakulasuriya's work being very popular. At some point of time, around the 14, I think, or 13, 14 time, this terminology started to change when he proposed another term called potentially pre-malignant oral epithelial lesions. So if you notice that small change in word, if you look at the previous slide, it is oral potentially malignant disorders. The other term now proposes a potentially pre-malignant oral epithelial lesion. So not just potentially malignant, but potentially pre-malignant. So why was this term used? This term was used to emphasize the fact that these lesions have the potential to become malignant. Yeah, that was the previous one also, right? Any lesion that becomes malignant, they called it potentially malignant. But what's new in this term is that even the current state, that is, for example, there's a leukoplakic patch, even before it became malignant transformation, it is probably an actual pre-malignant state. So if you have to actually rethink, brainstorm the definition, is it kind of going back to that old precancerous lesion kind of, you get a feel that they're saying, hey, it's precancerous lesion per se. That's what it's trying to say. Yes, it has potential to become malignant, but even the current state it is in, it can have a pre-malignant state. So that is what this new term is about, potentially pre-malignant oral epithelial lesions. Let's go a little further. So,
Excuse me, sir.
Yes.
So the slides are not changing.
Oh, I'm not sure which slide I'm in now for you.
Sir, the first slide, sir.
I'm still with that Manipal thing, is it?
Yes, sir. Yes, sir.
Thanks for letting me know. Can I, if you all don't mind, can you just log out for a minute and come back? Let me help.
Okay, sir. Sure, sir. Sure.
Thanks.
So screen, the upper taskbar has the option of slide share. If you click on it, it will become slideshow.
Are my slides visible?
No, sir, it's not visible now.
How about now?
So we are able to see the slides, but not in the slideshow.
Yeah, okay. I really don't know what. I thought as an expert with all this.
So the upper left-hand side corner will be the slideshow option. The upper corner on the screen.
Yeah, I understand. I really have to, but can slides are visible, is it, or not visible at all?
So slides are visible,
But
but
not-
yeah, only the first slide.
Okay, how about now?
Yes, sir. Yes, sir. We can see the slides.
That is moving, right?
Yes, sir. They are moving.
Thanks. At least that would help. I'm so sorry. I mean, I did put it on a slideshow. I'm not really surprised. For some reason, it's saying the screen sharing is paused. I don't know why it's paused. Okay, I'm sorry, but I want to ask you one last time. My slide is shown now, but I know it's not in slide share, correct? It's not in slide share, but you
Yeah,
can see
it's
my
not.
slide.
Yes, sir. Yes.
Dr.
Sir. We can see the slide.
Dr. Ravikiran. Dr. Ravikiran,
Sure, I can hear you.
this is Dr. Busreddy. You just mail your presentation to the host, and they will do it for you. They can show the presentation.
Yeah, I could do that. I mean, I'm so sorry. I'm waiting though. That's the problem. I could do
No
that.
problem, sir. You can mail your
Okay.
slides. Yes, sir.
Okay.
Yes.
I'll just get off this again and come back in 2 minutes. I'm so sorry.
Yes. Sir, I have sent the mail ID, sir. You can in your chat box. Hello.
Yes, I can hear you. I'll do that. I'll do it right away.
Yes, sir. Participants, kindly bear with us for a couple of minutes.
Okay, I did send you the PPT now. Can you please check? Yeah.
Yes, sir. We have received the PPT, sir.
Yeah, that's a relief. Thank you.
Sir, you can see the slides, sir.
Yes, I can, and thank you so much. Yes.
Okay.
Okay. Thank you all so much for bearing with me. Dr. Ajay, thanks for that wonderful idea. So we just go ahead now. I can actually operate my slides, right? Can I move my slides? Yeah, great. Y'all change it for me? Is that the way it goes?
Yes, sir. Yes, sir. I'll change it for you.
Yeah, you'll change it for me. So just leave it there now. Yeah, please leave it there. So what I was speaking, and you could just hear me, but could not see the slide, was I was just trying to tell you that for a long time we've been sticking to this definition of precancerous lesions and conditions. So where a lesion simply meant a morphologically altered tissue, whereas a condition simply meant a generalized state of the body, or it could also mean that it's just not one area in the mouth, but probably a larger involvement of the oral mucosa. And then this new term came up on oral potentially malignant disorders. I think that we covered, saying it could be any lesion or a condition that has potential for a malignant transformation. Okay, that's what's in vogue now in 2005. Yeah, please change next. Yes. So then this new definition came up where we started looking at this was actually proposed by Varnakula Surya, where he's trying to say this term was used just to say that just not that these lesions have a potential to become malignant over time, but and the current state that they're in. Even today, as the lesion is sitting in the mouth, it probably has a pre-malignant state. It's just that we do not know, but it could probably be having an actual pre-malignant state. And hence this term potentially pre-malignant oral epithelial lesion came to vogue. Next slide, please. So this was published in OOO, which essentially lists a lot of these oral potentially malignant disorders. Now, people, my time when we were in school, we had these list of precancerous lesions and conditions. A few things that were added and to this new list was that oral Lycanoid reactions was added, and graft versus host disease is a new addition. And I remember when we were in college, we were talking about Fanconi's anemia, which was part of the condition list that has been taken off that big list. Otherwise, epidermolysis bullosa and OLE, oral lichen planus, all these were part of what you had all studied, actinic cheilitis. The only new additions were Lycanoid reactions and graft versus host disease, and Fanconi's anemia was missing from this list. Next slide, please. Yeah, this is where it gets really interesting. So this is one of the updates that recently, I should say, October, November 2020, there was a WHO Collaborating Center for Oral Cancer. They all met up. They all met and had now a one consensus report. Okay, and they discussed about oral potentially malignant disorders. So most of the postgraduate students who have probably come across this article and presented in JCs would know such a thing existed. And I'm sure many faculty are aware of this new concepts that have now come into play. Now, what's OPMD? That is the oral potentially malignant disorder. Surprisingly, now, I mean, I personally, I don't agree to this thing of statistically increased risk of developing oral cancer. For many oral clinicians, it really doesn't matter statistically or no, but every single patient from a pre-cancer who turns into cancer is extremely worrying for us, right? So, according to this new definition, oral potentially malignant disorder is any oral mucosal abnormality, any, that is associated with a statistically increased risk of developing oral cancer. Now, why is this new definition so important? Now it's like everything is haywire, everything is left off. There's no talk of condition, there's no talk of lesion, there's nothing. It could be any abnormality in the mouth. As long as it has a statistically increased risk of developing oral cancer, you're allowed to call it an oral potentially malignant disorder. Now, in that consensus, that working group, they also said now there's a very strong evidence for oral Lycanoid reaction, also strong evidence for oral manifestations of chronic graft versus host disease to be considered as part of the OMPD spectrum. And now the new change is that epidermolysis bullosa is starting to show limited evidence of being OPMD. So in time, this could probably be knocked off. You may not soon see epidermolysis bullosa in this group of OPMDs. Next slide, please. Now let's, of all these OPMDs, I picked about 4 or 5 of them that would have some kind of clinical relevance. So let's look up leukoplakia initially. We all know historically a lot of different terms have been used for leukoplakia, but finally it was Kramer in 1978 that finally used this definition of saying this malignant potential of kind of a leukokeratosis and smoker's patch. And he said this was mainly due to pipe smoking. He was the first to describe this term, leukoplakia. And he also very interestingly said it was an elevated lesion that was involving the mucosa. And that's the 1984. This is one definition I really like. That was again, I think, adapted by Axel, which described, it was actually part of the international conference in Sweden, where I mean, most faculty would know this definition as students. This was the definition we all used to work with. Any white patch of plaque that cannot be described clinically or pathologically as any other disease and is not allied, or if you want to say associated with any physical or chemical causative agent, and we say except the use of tobacco. That seems to be still, I mean, it's 1984. Not many still agree to the definition, but to me, literally encompasses almost like the Pinberg's definition of OSMF, which is the classical gold standard. Personally, for me, I still believe this is what encompasses the correct definition of leukoplakia, because it's talking about everything that all the world workshops have been talking about, which they want to include, remove. Still, it cannot be described, so that's very clearly saying it's by exclusion. It's very clearly talking about tobacco as the main etiological agent. It's also saying no other physical or chemical agents. But it's a pretty good definition, I would say, the 1984 definition. Next one. And then 2007, there's this definition given by Newell Johnson and Varnakula Surya. These are people very well known in oral medicine circles, and they're working on oral precancers. So their definition is leukoplakia is a predominantly white plaque of questionable risk, having excluded all other known disorders and conditions that carry no increased risk for cancer. This is what 2007 they said. Then again, Varnakula Surya modified that definition where he said histopathologically also. But now what's very interesting is in 2020, the same working group I was talking about, they made this statement saying there's absolutely no reason to change the 2007 definition. And they say the 2007 is the most widely accepted in global literature. So for all practical theoretical purposes, we still have to follow, at least with regards to academic intent, that we need to look at the 2007 definition of Varnakula Surya, which is simply saying a predominantly, so what is leukoplakia? It's a predominantly white plaque of questionable risk, having excluded other known diseases and disorders that carry no increased risk for cancer. So that's our working definition until something else comes up, but it's the latest on the definition. Next, please. And this is just for theoretical interest, just to know that etiology is smoking. We all are very aware of this, but we just need to know that benzopyrene is the most powerful carcinogen for causing leukoplakia. Next slide, please. And alcohol by itself, we all know, is not really important risk factor for leukoplakia. But what it simply means is just by consuming alcohol, at least there is no major evidence to say that somebody would develop leukoplakia. It is only when it's combined with the chewing habit of tobacco. The reasons are very well known: increasing ambient temperature, easy entry of carcinogens. You're all aware of these. But just to let you all know here that alcohol per se cannot be, it's not really, there's no major evidence to say alcohol per se will cause leukoplakia. Next, please. And other ecological factors have been proposed in literature. HPV, diabetes, and association with candidiasis, a lot of dietary factors. And now in the last, I should say, close to a decade, a lot of talk about women having higher leukoplakic changes, and especially when it's not to do with smoking. They find that higher estrogen levels also seem to have a role to play with leukoplakia. Okay, what are the hallmarks that we're going to look at? I think one of the reasons why they're usually diagnosed after the 4th decade of life, especially in an Indian context, people do report only when they begin to see a change. So it's mostly in the middle age that people come to a clinic, especially when they start to notice. They're more aware of their oral cavity, or they went out for some kind of dental treatment, somebody pointed it out to them. So that's again a little, to me, very questionable and debatable, because the if you actually look at what age somebody actually starts smoking, it's in their teens and early 20s. So for leukoplakia to develop 20 years is a little questionable for me. It's just that maybe the time when we see it, that's fine. So I don't think age, which is a common age to see leukoplakia, I'm not sure that's the right way of looking at it. And again, males are more common. Smokers, we all know that's definitely there. This is again something very interesting. Some leukoplakia is idiopathic and may not have a known risk factor. Most of, again, literature we look at, the so-called idiopathic leukoplakias are more written in the Western literature. We don't have Indian, if I look at Indian literature, people do mention of idiopathic leukoplakia, something like a rare case report. So nobody really in the West talks about a rare idiopathic as idiopathic cause for leukoplakia. So it's probably the reason is a lot of use of tobacco in the Indian subcontinent compared to maybe HPV and other risk factors in the West. With regards to the Western population, literature talks about the lateral margin of the tongue and floor of the mouth as the common sites of involvement. Whereas in the Asian population, it's more on the buccal mucosa and the low vestibule, probably the tobacco-related habits that we all used to. And the Western population more to do with, I'm assuming, HPV. That could be one of the reasons those common sites. Again, not many papers to talk about why exactly lateral margin. There have been anecdotal reports why it's there, more to do with HPV association. Next, please. So the clinical types, this hasn't changed much. Of course, we know over time proliferative varicose leukoplakia was suggested, but otherwise nothing's really changed with regards to the clinical types. It's the same use of terms like earlier we used to simply call it red and white lesions. Now people use terms like thin, and if you look at some books, they talk about thin leukoplakia, those terms like that. But it's nice to simply say whether it's homogeneous or a non-homogeneous type of leukoplakia. And if it's non-homogeneous, you would use terms like speckled, nodular, verrucous. Speckled over time is generally taken over by erythroleukoplakia. Not many use this term of speckled leukoplakia now. They prefer to use erythroleukoplakia and then nodular and verrucous type. Next, please. Now going to erythroleukoplakia, like I mentioned earlier, it is, now we don't tend to use the term of speckled. This again, the consensus group talk about just the same component where of leukoplakia, just that there's more atrophy or thinning. That's what they say. And the other important need, it should be pretty irregular margin. It should not be clear, nice patch like leukoplakia. It should have an irregular margin, and patient should complain of some kind of soreness or burning sensation. Again, literature shows a lot of candidal colonization of these erythroleukoplakic patches when compared to a plain leukoplakic patch. Yeah, so this is something interesting again with regards to proliferative varicose leukoplakia. There are certain criteria that have been proposed as to what one should call it as one should diagnose as proliferative varicose leukoplakia. One of the most important requirement is later than 2 sites. There should be at least more than 2 sites of leukoplakia. Again, that's not, it's not, should I say, very it's not that it's very critical that it should involve gingiva alveolar process or the palate, but it's been shown that PVL is more commonly seen with gingiva alveolar process. But it's important that any leukoplakic lesion, but it should have at least more than 2 sites. That's one of the requirements. There should be some existence of some verrucous area to call it PVL. Second, lesions that have spread or engrossed during development of the lesion should show some kind of a growth. It's not, it should not be very quiescent and quiet. And then more importantly, if you treated leukoplakia earlier, imagine there was a homogeneous patch, you treated the patients, maybe with antioxidants, maybe with vitamin E analogs, or vitamin A analogs. If the patient comes back with a recurrence in a previous treated area, that's also a good pointer saying this could likely be a proliferative varicose leukoplegia. Also good to note that all PVLs do not need to have this varicose kind of finding, especially when initial stages. Now this is very interesting. If you look at the statement made by Aguirre is one of, should I say, collaborator with Saman Vanapurusuriya. He proposed an alternative term, calling it proliferative multifocal leukoplegia. His argument is, if there are more than one site or more than two sites, if that is really important, then might as well call it a multifocal kind of a leukoplegia rather than proliferative varicose leukoplegia. Based on the previous statement where I mentioned that all PVLs need not have a varicose finding, okay, then if all need not have a varicose finding, then might as well look at multiple sites. If it's multiple sites, you might as well call it a multifocal leukoplegia, proliferative multifocal leukoplegia. So PVLs can be probably an alternative term. Again, I'm not sure, evidence-based, not sure how many would agree, but it's a good that's his proposal to call it a proliferative multifocal leukoplegia. Next, please. So again, this we're very all familiar with the Vanderwaals classification of the OLEP. We may not go into this. After you look at leukoplegia and stage it. Next, please. Yeah, this is interesting. Again, by Vanderwaal. This is a pretty old article in Oncology 2009, but it gives us some kind of a certain way of diagnosing oral leukoplegia. When would you say, I will call this leukoplegia? So C1, what he says is evidence from a single visit. When you apply inspection palpation, that is only based on clinical examination. Pick up a mouth mirror, examine clinically, and if you palpate the lesion, patient does not have history of burning sensation, has tobacco chewing or smoking habits, and you're seeing a white patch well demarcated, then C1 is when it's a single evidence. You just have a look. C2 is you eliminate other factors. For example, there's a sharp root. Patient has a chewing habit, has a sharp denture. Eliminate all those restorations that are impinging on the lesion, ill-formed crowns. If you get rid of it, in end of 2 or 4 weeks, recall back the patient. If you still see this lesion there, then you say there's evidence. I removed all the etiological factors. I still see a white patch, so I can call it leukoplegia. That's another way of defining leukoplegia. The third is a little more definitive, where you're actually going in for an incision biopsy. Histopathologically, it's supporting your clinical diagnosis. And finally, based on surgery, a surgery done, and then you histopathologically examine based on the resected specimen, then you call it C4 evidence of leukoplegia. Next, please. Okay, so this is, I should say, almost like the position paper on leukoplegia. In the end, 2020, the working group now came up with these 6 or 7 lines to call it what is leukoplegia. The first requirement is a predominantly white patch of plaque that cannot be rubbed off. That's the first statement. Second, it should be a homogeneous leukoplegia with effectively circumscribed, which should be very well demarcated borders. Okay. Next, it should, if it's non-homogeneous type, it should have very diffuse borders. There should be no evidence of chronic traumatic irritation. I mean, you should get rid of all these sharp teeth, sharp dentures, everything that you can eliminate with regards to causing a traumatic keratosis for that matter. And then it should not be reversible on elimination of, so you remove that cause and suddenly it disappears, it's likely not to be leukoplegia. Then it should not disappear. We all know this as leukemia, right? So if it's not leukemia, so this is now the working group diagnostic criteria. So we are essentially looking at these 6 points when you see a white patch. If you see it, all these 6 points get a tick, then it's likely to be a leukoplegic patch. So non-invasive diagnostic tools, we all again know it's a small, it's a lesion, small tiny one. It's amenable for biopsy. It's easy, but suppose it's a big nice patch, you need to take the most representative side because you need to check if there's dysplasia. Then you can use a simple vital staining procedure and a big list. Now, since we are looking at some kind of advances and what can be done a little slightly more advanced, probably to the end of the lecture, I'll spend about 5 odd minutes on some advances that at least we've been working on advanced diagnostic tools. Please skip the slide. Next, please. So finally, what we would say is leukoplakia, at least for me, is a provisional clinical diagnosis. Maybe if somebody has to ask you, and why did you do a biopsy, or why one needs to biopsy, this is especially for the postgraduate students, why biopsy is mandatory. One reason you'd want to take a specimen is to exclude other pathologies, or maybe even saying, I even don't know this white patch is carcinogenic. I don't know if there's a carcinoma there. So you will want to take a biopsy from it. Second, you want to check the degree or the severity of the dysplasia within that patch, then you'll want to go for a biopsy. The third reason why I do is maybe an exfoliative is good enough to probably check for candida, but a biopsy gives you more better checking for candidal colonization. So there's only, I would personally think, three only reasons why somebody would want to think of a biopsy from a leukoplakic patch. Next slide, please. So differentials, just to complete, differentials will be a chronic hyperplastic candidiasis, lichen planus. Again, the reason I'm not really categorizing it much with regards to lichen planus, I mean, as a faculty, I would like to specify more and say I'd like to see block kind of lichen planus if I'm looking at homogeneous white patch. If I'm looking at a non-homogeneous variety, I would probably say erosive lichen planus, and then of course white spongineous. And the rest are all to do with more of specific etiologies, for example, friction or placement of tobacco quid or a cheek chewing habit. These will be all related to some kinds of trauma inciting keratosis. But otherwise, the first three would hold good for differential diagnosis. Okay. I mean, again, a lot of literature shows a lot of wide range for what's the malignant transformation rate. These are different studies from different groups, ranging roughly from about 0.13 to about 19.8% that chances of leukoplakia turning into malignancy. Especially, we need to understand this concept of a high-risk oval. So these are sites that have the most, should I say, the most potential to turn into malignancy, especially floor of the mouth, tongue, ventral surface of tongue, facial pillar region, the soft pelvic region, the tonsillar areas. So these are sites that have higher chance for malignant transformation if the leukoplakic patches present in these sites. This is again a 2021 article. These are things that, because I just mentioned about malignant transformation rate, I found a few which are talking about factors that influence malignant transformation leukoplakia. The first one I see there was female gender. I think that the parallel I was trying to draw earlier with estrogen, I mean, studies need to be done a lot more in detail, longitudinal, where they're trying to propose the role of estrogen and then saying female genders have more malignant transformation rates, especially if they have a leukoplakic patch. Longer the duration of leukoplakia, yes, that's very obvious. Patient's age, size greater than 200, so that millimeters square. So the larger the lesion, it's believed there is greater chance for a leukoplakic transformation. Of course, the non-homogeneous type we all aware. And the last point I just mentioned about the high-risk oval. So these are sites which have more propensity to turn into malignancy. Okay, this is just to finish off with leukoplakia. This I just picked up from my own book for management of leukoplakia. I do not spend too much time because we all know start off with candid mouth paint, and then if you're suspecting the dysplasia, biopsy. The mainstay is of course lycopene, antioxidants. Literature also shows the use of bleomycin. So we can just skip this, I guess. Yeah. Next. Please. Okay, there's a lot of, I mean, I just thought I just put this article here because I see a lot of discussion happening with regards to laser. No offense to anybody, but a lot of people do mention about leukoplakic patches being treated well with laser therapy. Honestly, I haven't done not a single case of laser for leukoplakia, but at least with what literature I've seen, this seemed to be the longest follow-up. This is for like 36 months. Somebody did a follow-up for 36 months on after doing use of laser. So I was surprised to see that though like almost like half of the lesions resolution occurred, I was also surprised to see in about 13 patients, we look at that 13 patients, leukoplakia recurred out of those 37 patients. 8 patients, leukoplakia turned malignant. So I'm really surprised because, to be again very honest, not many, we all should be know that not many patients, especially of leukoplakia, come back for a review in spite of calling them back. So for 36 months, after roughly 3 years of follow-up, almost I should say like what 30% of them turned into cancer, and then there was a lot of recurrence. So still debatable about carbon dioxide laser. So the outcome was, it said though the carbon dioxide laser was efficient in removing the lesion, it did not avoid clinical outcomes of recurrence or malignancy. This is just a question if you want to know what's happening with laser with regards to leukoplakia. Next, please. Okay, so as of I should say about 1-2 years back, what I could see was the only molecular marker that has been validated prospectively in patients who have high risk for developing oral cancer is loss of heterozygosity. So that's the only molecular marker that has been validated as of now, prospective. Yeah, next, please. Okay, so that was done with leukoplakia. It's about 330 now. I'll go to oral submucous fibrosis. So this is the classical gold standard definition of oral submucous fibrosis. Because with pleasure and a lot of times, I mean, with happiness, you always read this definition, because I always tell my students that no matter how difficult this definition looks, it literally has everything that you need to know about oral submucous. So it's very simple to know that it's insidious, it's chronic, and affecting any part of the oral cavity at some time to pharynx. So this is trying to tell you how widespread this can be. And then the definition goes on to say that may or may not be associated with vesicle formation, but always there's juxtaepithelial inflammatory reaction. So the kind of inflammation happening within the epithelium. And then there's fibroelastic change of the lamina propria with epithelial atrophy. And this kind of fibroelastic change is what causes the stiffness, stressness, and why they can't eat is because of epithelial atrophy, this burning sensation. So this definition will actually give you most of the clinical features. It will also tell you how to treat the patient and what you need to target at when you treat the patient. So you need to take care of inflammation, you need to take care of the burning sensation, and you need to take care of the trismus. So these are 3 things the definition will give you. And that's pretty much the most popular and I would say the best definition for OSMF, personally. Next, please. So going to etiopathogenesis, we all know that alkaloids and flavonoids in areca are considered to be the most significant or probably the only etiology. It's so popular that areca nut chewing, which contains alkaloids like arecoline, arecaidine, and the flavonoids, do cause oral submucous fibrosis, because ultimately it causes some kind of, it's cytotoxic essentially. And also this constant chewing of areca nut, which is that coarse substance, because all across India, the chewing habits are slightly different. Some chew the inner part, the endosperm, that's the part, the inner part of it, which is the nut, the areca nut. If you go towards the northeast, even to places like Thailand and Malaysia and all these places, the outer husk is also eaten. It's soaked in water and the people chew on the outer husk. It's believed the coarse areca nut as well as the part of the husk itself is enough to cause the constant micro trauma and friction, which causes the juxtaepithelial inflammatory reaction, apart from the alkaloid steps. Also, a lot of talk about copper upregulation. We all know about the Lycanogies pathway. There's a lot of copper upregulation that causes increased collagen production in OSMF. So, next, please. Yeah, so anecdotally here, I should mention, I mean, I'm not sure, I did see earlier Dr. Ashok was there earlier, I'm not sure if he's still around, but he surely knows Dr. Suman, Dr. Rajeshwari, and Dr. Ashok were here. So when Suman was working here with us in Bangalore, he was always talking to me about, and he was very passionate about OSMF, Dr. Suman. He's in Malaysia now. He was telling me that because I had come from Bangalore, and when I came here to Mangalore 20 years almost back, he was telling me about places in this part of Karnataka, especially towards Sagar, where they grow these lot of these arecanut plantations. Even Mangalore has a lot of arecanut plantations. Very surprising, though literature talks about arecanut chewing causes OSMF. Literally, we actually went on a site visit to something called a CPCRI, which is a Center for Plantation Crops of Research Institute, where we got a lot of information of arecanut. And there, the people who climb these areca farms to pluck the nuts, one of the discussions they have with the owners is, yes, you can pay me money to bring these areca nuts down, but you should let me chew as many as I can. You should allow me to do it. And these areca nut pluckers actually climb from one tree to other. When they chew on areca nuts, surprisingly, none of them, I should say, has ever developed or shown OSMF. So this whole theory of that's all in literature talking about everybody who talks about arecanut being a cause. It's really surprising that people who chew arecanut do not have OSMF. It's very surprising that way. And then this whole story about copper and high content of copper. So we did a couple of studies, and I just come to that now. Just to, can you please change the slide, please? Yeah, so this is the arecanut I was talking about, and this whole arecanut goes through a lot of process. For people who are not very aware, you have something called a red and a white variety. So essentially, the arecanut takes about 8 to 10 months as it matures. It's believed the more mature this arecanut becomes on the tree, the more mature the arecanut is, the amount of alkaloids go up and the antioxidants fall. And the more tender varieties that I was just mentioning, these people who climb on trees and pluck and eat them, in the earlier stages, it's very, very tender and has high antioxidant levels and very less alkaloids. So it's believed that these high alkali content comes only with maturity and only comes after these nuts are processed. Next. So during that point of time, just to say if arecanut was really bad, what we did at MCORDS Bangalore, again with Dr. Suman, what we did was to take different varieties of arecanut, and what we had studies on animal models. So we used Vista albino rats. So literally the arecanut was powdered. We have something called a red and white variety of arecanut that's powdered. Use a camel paintbrush. The buccal mucosa of the rats was smeared with arecanut, and this period went on about twice, I think in a week, vaguely if I recollect, twice the application was done, and for a period of 6 months in Vista albino rats. End of 6 months when we studied, you'll be surprised to see, I mean, the graph there is right with you. When areca was added with tobacco, you'll see literally all those changes that are taking place. Whereas just arecanut did not show as much as change that you would expect. So plain arecanut did not have, though I told you it's the mature variety, right? So it had alkaloids, but when you add it with tobacco, it starts behaving a little differently. Next, please. Similarly, I went on to, because we know arecanut, a lot of people in India have this habit of quid, right? It's not just arecanut. So you have a pan, you have betel leaf, and you have various things like areca, you have betel leaf, you have betel nut, the slake lime, all that goes into it. And just to talk about what's the copper content, I did a study to see what could be the copper content. We are shocked to see copper content was high in betel leaves rather than nuts. So again, that's a lot to be studied and research furthermore to see what are those causes for having these. Believe the soil content, the water, everything has a bearing. But I was surprised to see just not the nuts, but the betel leaf also seem to have very high copper content. Next, please. Okay, the other genetic factors that have been implicated for OSMF, right, from HRV, a lot of other things. Okay, we can skip this. Well, nothing new. No major updates here, so you can continue that. Next, please. again a very good article that I found with regards to ultimately, if you look at the molecular pathogenesis of OSMF, the study by Rajalalita ultimately came up with the saying the transforming growth factor, which might be very critical for the pathogenesis of OSMF. That's the only thing that seemed very interesting with the study. Next, please. Okay, so we all know these are various changes that can take place with regards to OSMF, right from very early stages of pallor, burning, blanching, and if any students here, postgraduates or undergraduates, just to clarify a little bit on the pallor and blanching of mucosa. We seem to use this very interchangeably, but nice to know that pallor simply means paleness. When you examine, you cannot see the mucosa is blanched without touching. So blanching of the mucosa is when you actually palpate, and then you say, okay, now the mucosa is blanched, but just by looks, just by inspection, you cannot use the term blanch. It needs to be palpated. And then as the habit now, interestingly, in India, you have these various habits of chewing. Some could actually chew and spit out, some would chew and swallow. Based on this habit, the clinical features would change. So somebody would chew and spit out would have the circumoral bands, and somebody would chew and swallow the betel nut juice and everything as it comes out of the quid. They start to have these uvulary changes, soft paddle involvement, and hearing loss because of stenosis of the eustachian fluid. Next, please. Okay, these are typical marble-like appearance of the mucosa. You are very familiar with these kind of appearances. So one of the characteristic features is marble-like appearance. Now, when the soft palate is involved, palatal changes that you see is again, you see a lot of pallor there on the mucosa, and the uvulary changes that you see is based on the severity of the involvement of the uvula. If the uvula partially is involved, it would have the typical hockey stick shape uvula where it's pulled to one side, whereas the total mass of the uvula is involved, then it could be shrunken and bud-like. And that the typical purse string appearance, that is, if the circumoral bands are involved, then you use a term of a purse string kind of appearance of the mouth. Next, please. That's the same thing with tongue involvement. Okay, so the loads of classifications, and what's heartening here to see is you see a lot of Indian names there, so it's very nice to see many other people already know a lot of people here on the left-hand side. You see a lot of classifications that are used. The most popular that we all keep talking is the next slide, the Kanna Andrade, a lot of, and the Hyder's classification. Next slide, please. Now, one before this. One, okay, now, next, please. Yep, next, one more. Next, one more. Okay, so I got rid of the slide. Okay, one back then. One back, one, yes, okay, we can stick them. So the most popular ones are Kanna Andrade, and then Haider et al. Had a good classification. What I found very interesting with this classification, what's there right on the screen is for people to go check back again. This is by Dept of OMR. It's a wonderful classification. It's a little elaborate and a little extensive. But this is very elaborate and extensive, but it generally encompasses everything else, right from clinical to functional, histopath, and treatment, and essentially progressing. So Dept of OMR, I think it's 2017, if I'm not mistaken. So this is a good classification. Just to go through one of them. So if you look at grade 1, he's saying involvement of less than 1/3 of the oral cavity, mild blanching, burning sensation, recurrent ulcerations, and dryness of the mouth. And there's something to do with mouth opening and what histopathological change you see and what should be our ideal treatment. I mean, we could make small adaptations to this when we treat patients, but generally this seems to be more relevant, and I mean, I like this classification on Dept of OMR. Okay, next please. Yeah, so differential diagnosis, this can be debated any number of times. OSMF, it's very straightforward, but if somebody wants to really know what could probably be the differentials, then scleroderma is one. Considering there's burning sensation and the paleness of the mucosa, there may be anemia can be used. And of course, generalized fibromatosis. Next, please. Okay, so again, putting it multiple times to say OSMF clinical examination is more than sufficient. But say you did send the patient out for some investigation, then all you see is an increased ESR. It's inflammatory in nature, just to confirm that. There have been instances of showing vitamin B complex levels, reduced iron levels. It's all I assume is because of inability to eat and there's reduced protein levels too. Next, please. Okay, this again a good article by one of my own colleagues, Dr. Ajit, now in Canada, along with Sumant. This was published very I say a so-called General Dentistry Journal or Journal of Canadian Dental Association, but it generally summarizes a lot of things right from micronutrients to immunized milk, lycopene, steroids that can be given. Can you move to the next slide, please? One before. Yes. No, next, sorry, next. Yes, thank you. And this talks about, we all familiar with hyaluronidase and use of steroids and then placental extracts. He also gives mention of turmeric and then use of hyaluronidase with dexamethasone. So this is generally giving all that one needs to do with OSMF treatment. Next. And then of course there's surgical management, which we are all as oral physicians not very happy with surgery unless the mouth opening is really poor, less than about sometimes 18, 15 mm. It's only so bad that you can't really medically manage the condition, then I would think surgery is generally not an option for many of us. Next. So this again I picked from my book. So either of the stages, either 1, 2, 3, or 4. The keeping into mind, if you have to go back in time and look at grade 1 to grade 4 of Deepak Percy, then if you have to adapt it here, it will just look like at all stages of OSMF, you'd rather give systemic supplementation with iron supplements and antioxidant capsules. And of course, topically, there's burning sensation, tantamolurins, your very popular tantamolurins, which has benzidamine hydrochloride. And then topical steroids can be used, and immunomodulators also seem to have a role with regards to managing OSMF. But we all know it's an irreversible condition. So this we could continue repeating this for relief of symptoms. Physiotherapy has a big role with regards to managing OSMF. In fact, in our own clinics, right after injection of intralesional steroids and hyaluronidase, we actually urge the patient to get a balloon. So right after the injection, we asked him to sit on the dental chair and he's actually blowing the balloon, hopefully causing some kind of pressure internally to help that diffusion of the steroid and hyaluronidase. Okay, about 3:45 now. So look at oral lichen planus. Next slide, please. Okay, so there have been a lot of definitions for lichen planus, but the one below that I mentioned seems again very more encompassing and seems to be doing justice to what lichen planus is all about. So we simply call it a chronic inflammatory disease that affects the mucous membrane of the oral cavity. It is a T-cell mediated it's a T-cell mediated autoimmune disease in which cytotoxic CD8 cells trigger apoptosis of the basal cell of the oral epithelium. Now the one that's right on top, a chronic immunological inflammatory mucocutaneous disorder, holds good just for the dermatological lesions of lichen planus. But if somebody wants to know what's the definition of oral lichen planus, then this one with the histofat will actually hold good. Okay. A lot of different theories have been proposed, right from genetics to dental materials, a lot of things, but the most accepted is still the T-cell mediated disorder. There is production of cytokines, which causes apoptosis. Okay, next, please. So to me, the easiest way of understanding pathogenesis is whenever you have any antigen entering into the body, these Langerhans cells will detect the antigen, presented the T lymphocytes, and then in turn, what will happen is there's resulting in cell-mediated immunity. But what happens in turn is every time these T lymphocytes are activated, they'll again release lymphokines, and this process goes on causing destruction of the basal layer and then causing lichen planus. Okay, so this actually hasn't changed. So there's absolutely no update with regards to lichen planus per se. Oral lichen planus is still what Anderson talks of 1968 dividing. It seems very nice. It hasn't changed much. The 6 types have remained the same, and each of these can manifest either as a hypertrophic form, an enzymatic form, or a bullous form. Yeah. Okay, so this is just one small debate that we keep having. If that's an update, then is a pigmented form. Should we really consider the pigmented form to be a part of this whole spectrum? So majority what is seen is, especially with regards to erosive type of lichen planus, not the should I say not the plaque kind, but especially when the lesions are erosive, then it's believed that as the lesion heals, we all believe that's a post-inflammatory pigmentation with regards to lichen. Now, if you look at the second statement I'm making, the lesion presents as a reticular white lesion surrounded by brownish to grayish plaque pigmentation. So you need to take that with the upper statement to saying every time you see some kind of erosive change of lichen planus, imagine you treated the patient with topical or systemic steroids. As a part of a healing lesion, when you call back the patient, you'll now start to see reticular white lesions. Maybe the small areas of erosion would still remain, but at this point of time, you'll see a lot of brownish and grayish plaque pigmentation. So we believe pigmented form is more like a post-inflammatory pigmentation form of lichen planus, may not necessarily be a separate entity of lichen planus. Okay, what's the malignant potential that you see? Varies again 0.4 and over 5%. Surprisingly, lichen planus seems to have a lesser malignant potential compared to oral leukoplakia, which goes almost like 19%. But again, we are not very sure. We can't really compare this. It's not really apples to apples because you never know if that 5 to or rather 19% dimension as a maximum. We're not sure if it's proliferative verrucous leukoplakia. We really don't know what type they're comparing. Even here, the reported frequency that I'm talking about from 0.4 to about 5%, we are not sure whether it's the erosive form of lichen planus. But then we all need to know is the reticular form has the best prognosis. Okay. Yeah, this is again taken from my book where we're just talking about different forms of treatment for lichen planus, summarized quite a bit in detail. I think I'll not go into it, but for now, just understand that steroids are the mainstay for treating oral lichen planus. Next, of course, recalcitrant lesion, azathioprine have been used successfully. We had some success too. Poor therapy, again, a lot has been mentioned, but I have no personal experience of using poor therapy. Newer drugs, mycophenolate, mofetil has also been tried, tacrolimus, sirolimus, all these have been tried, but still the mainstay would still be topical and systemic steroids for lichen planus. Yeah, this is a few minutes here I'd like to spend. Now, I'm not sure if it's only me or generally we use this term oral lycanoid reactions, but literature actually shows these used sometimes interchangeably, sometimes as in 2 different places in the same article, sometimes lesion, sometimes reaction. So if I go back again to that working group consensus 2020, they use the term oral lycanoid lesions. So oral lycanoid lesions, they lack the typical clinical or histological appearance of oral lichen planus. They may not be symmetrical and they could be unilateral. That's what we've been learning, right? This is a very favorite question for most examiners. How do you differentiate lichen planus from lichenoid reaction? So lichen planus, you'll always say that it's symmetrical, it is bilaterally present, but here you're generally saying that lichenoid lesions, not reactions, lesions, they're present either unilateral and not symmetrical. Next, please. Next. Yeah. Now, what are the types of these oral lichenoid lesions? Okay. So there are essentially, if I have to group them all, there are totally 6 types of oral lichenoid lesions. The first one is atypical oral lichen planus and unilateral lichenoid reaction. This was given by Vandermeer. And then the next one is lichenoid lesions that are in close contact with a dental restoration. That's also the other name for this is oral lichenoid contact reactions. That's a new name. Then there's something called a Lycanoid drug reaction that is associated with the drug. Then there's some oral lesions with intake of food substance. Then lesions of graft versus host disease. Now this is a little controversial because now that E point where I mentioned oral lesions of graft versus host, in the new working consensus 2020, they pulled it out and now made two separate entities where oral Lycanoid lesions plus graft versus host are two different entities there which come as part of the PMDs. And then finally, this is a new addition by Vanakula Surya, who's talking about a contact reaction to beet liquid. I mean, majority of the hospitals, dental hospitals in India, we know what this beet chewers mucosa, beet liquid related Lycanoid reaction. We keep using that term, right? So they also mentioned about a Lycanoid contact reaction to beet liquid. Next, please. Okay, so this is very interesting to read this. So I'll just put this out quickly. So we all know it's a diagnostic challenge to clinically distinguish between lichen planus and Lycanoid kind of a reaction. So Agire again, 2020, he works with Vanakula Surya. So they proposed under a term now called oral Lycanoid disease. So he's combining both. He's combining this an update again. They try to combine oral lichen planus along with oral Lycanoid lesions as one big disease called oral Lycanoid disease. Okay, so that's a 2020 proposal. So what they're saying here is, now what are these oral Lycanoid disease according to him? He says it's a potentially malignant disorder of the oral mucosa that cannot be clinically or histopathologically diagnosed as any other specific oral disease. Oral Lycanoid diseases encompass both lichen planus and Lycanoid reactions and characteristically show what white papules. This is the typical Wickham stripe we keep talking about, the reticular lacy network, and sometimes accompanied by other types. It could also have other types, we say. It could be erosive, ulcerative. So pretty hazy when he says everything to do with, actually if I look at the definition, it's talking more to do with lichen planus there because it shows white papules, it has reticular formation and everything else. But anyway, now the suggestion is to combine both as oral Lycanoid disease. And then the last line that's mentioned there shows that patients with oral Lycanoid lesions have more or less similar malignant potential to oral lichen planus. So we need to treat, for all of us, we all have to now say we have to treat oral Lycanoid reactions also with more respect. For me, at least, we generally say, okay, it's Lycanoid reaction, probably a patch test, probably get rid of the restoration, ask the patient to discontinue habit. But I think we need to put them all under follow-up to see how they turn out because they seem to have the same malignant potential to oral lichen planus. Next point, please. Next slide, please. Okay, erythroplakia, nothing has really changed right from our own times of Schaefer times. When we talk about erythroplakia, the erythroplasia of Herat, people talk about that very similar thing, a fiery red patch that has not changed again with respect to the 2020 group. They also describe the same. They have not changed anything with erythroplakia. They left it like the way it is. So they say it's still that sharply demarcated, flat or depressed red area of the mucosa with a matted appearance. Okay. So if it has nothing changed, even the 2020 working group, same definition for the last 3-4 decades that it is a red patch, it's well demarcated and has a matte appearance. Okay. Next. Next, please. Okay. So that's all, nothing much from here. Yeah, the last point importantly, what I put in red, we should know that most erythroplakias at the time of diagnosis are either histopathologically a squamous cell carcinoma or show a high grade of epithelial dysplasia. So that is very important. So the moment we see these erythroplakic patches, day 0 is when you advise a biopsy. There's nothing like, let me treat, call them back, let me review, let me follow up. The working group, the one statement that they're making is most erythroplakias are already squamous cell carcinoma. So they show very, very high grade of epithelial dysplasia. Next page. Okay. Few other things that are under the new gamut of potentially malignant disorders is OLE, oral lupus erythematosus. So we all know essentially they're classified as systemic drug-induced or discoid. That's the last statement again I want to pronounce yet very simple is carcinomas developing within lesions of OLE are rare intraorally. Most arise on the lips. So if you see lesions on the lips, now how would OLE appear is what you have to go back to Odell where they're saying is a central circular zone of atrophic mucosa with a superficial ulceration surrounded by white stripe. Now OLE for many of us, if you actually look at OLE, clinically it's super difficult to make out if it's how to distinguish from oral lichen planus. Absolutely difficult. It will have the same presentation, OLE and oral lupus erythematosus and lichen planus. They have actually the same kind of features, but very rarely would you see an OLE lesion seen on the lip. So if you see the so-called lichen planus lesion that we all call lichen planus on the lip, it's likely to be OLE. That's what the 2018 article is talking about. Next, please. Okay, so that's about 4 o'clock now. I was expected to speak until 4. Ma'am, Dr. Chai David, ma'am, if I can get another 5 to 10 minutes, is it okay? Can I get 5 minutes?
Yes, sir. Sure, sir.
Yeah, thank you. Yeah. So a few slides on the advances, and I mentioned earlier that I'll show you some advances. At least we've been working with diagnosis of all OMPDs. It's not just to do with cancers, but including pre-malignant lesions. I'll go to some tools now. Next, please. So the last 20 odd years, we've been looking at basically, at least I've been working with the Department of Atomic and Molecular Physics for the last 20 years almost on just one thing is potentially malignant disorders. How do we diagnose them early? That was the big challenge for us. We did not want to start diagnosing when you saw morphologically changed condition. Now, majority of the tools that we have, right from Visilite to everything else that's available, all the kind of fluoroscopic techniques that are available, all of them need that change of the mucosa. You need to say, hey, this mucosa looks bad. Now I point my laser there and then say, okay, what's gone wrong? Question is, a patient is smoking, and now you want to know how bad is the mucosa. Is it good or bad? You cannot even see, right? Clinically, a patient who's smoking, when you see it looks very normal and nice. But what is happening underneath the mucosa? Can you get an idea of what's happening? That's where the thought began. And I'll just go through a few techniques to mention. One of the techniques is called high performance liquid. Next slide, please. One of the techniques is called high performance liquid chromatography, HPLC, which is just a way of separating out various materials with laser induced fluorescence that you're combining both together. So what we did was to collect saliva from patients. You put the saliva specimen into the HPLC machine. The HPLC will break down into various components of saliva into various protein molecules. You have a thin quartz capillary, so the protein molecules keep exiting one molecule at a time. As the molecule is exiting out of it, use a laser with a non-wavelength, strike the protein molecules here, and right away, real time on the screen, you see an optical signature. So if you look at, I just projected a few optical signatures. For anybody who is not even blind, I mean, all you need to be is not to be blind, right? If you just look at some pictures here, chromatograms, if I look at the right on top, you see normal saliva specimens, you see that some signature coming up, right? Look at the ones at the bottom. Patients who are smokers, you suddenly really see that the peaks on the left-hand side are totally vanished. You don't see any of these guys at all on the left-hand side. This kind of remains, the architecture remains, but this is missing. And look at pre-malignant samples. They start to behave so abnormally different from a normal. And trust me, every single leukoplakia, every single lichen planus, every single submucous fibrosis had similar spectral signatures. Now, what does that mean? It means that every single peak or small mountain that you're seeing here denotes a certain protein molecule. Now, God alone knows what that protein molecule is. As of today, a few of them have been identified, not many, but that profile remains the same. Exactly at that spectral wavelength, that exactly that time, that protein molecule is eluted. So just by looking at it on the screen, you can say there's something going wrong. At least that's the first step you can do. Next slide. Okay, so that's to show you the salivary profiles. Even for you to see, you can just see the ones on the green, shows you normal spectral signature. It means if you're looking at about 200 seconds from its time it exits out, you'll see a small peak for normal. Suddenly in pre-malignant, that's missing. Malignant is totally a different profile altogether. And this repeats any number of times you take a normal salivary profile, it has the same signature. Every time you take pre-malignant, the same signature. So this, the time elution, if you look at it at that specific second, if you look at that 1200 odd seconds, you'll see alpha amylase. See that high peak of alpha amylase there. Okay, and you hardly see in the normal patients so much of there's no emission at all there at that point of time. So these peaks will remain, these protein profiles will exactly remain the same. So this could be a good, nice way of diagnosing oral precancers, even before any morphological changes seen in the mouth. Next, please. Okay, we can just skip these two, I guess. Change this. We can change this too, since I mentioned. Yeah. Now this is with serum. This is with one slide back, if you don't mind. One slide back. One slide back. That's one. Yes. So that was what I mentioned was with saliva. That was totally, should I say, non-invasive. This is slightly invasive because we are taking now blood samples from patients. So we did the same with blood, and we literally found that these profiles again, blood had its own way of protein profiles that it exhibited to us. And we could actually identify certain peaks there. If you see human serum albumin, CPK, transparent, all of these remained exactly the same. So it's so simple. It's like real time, almost like 30, 40 seconds on, and then you start to begin to see this profile seen on the screen. Next, please. Okay, we can skip this because the same slide there. We can skip this. Okay. So what I did mention was an old technique, old as actually about a decade old now, called HPLC-LS, where you're actually taking saliva, you're taking serum, putting into a machine called HPLC that separates out all the protein molecules, and then you excite it with a laser. The second setup, the demonstrable setup that we made, that was about a decade back, is now a kind of a probe. Next, please. Yeah, so this probe can actually be held in the patient's mouth. We can leave it probably. Yeah, don't worry about that. So that's okay. So this probe is held against the mucosa, and this patient does not have any change. It's just normal mucosa. Next. And now real time, you will see that these are the more major fluorophoros we're looking at. The fluorophores you're looking at is NADH, collagen, flavin, elastin, and different wavelengths. You see a lot of excitation profiles, and you see these peaks. We can change that. Next slide. Okay. Yeah. Click on that. Yes. Okay. That's NADH and collagen much lower. Okay. So that excitation, now you see that two small peaks, right? So this is normal spectrum. In a normal patient, you are expecting to see the collagen peak like that and NADH peak. Next, please. Yeah, so in normal abnormal tissue, this is what would happen. You'll be surprised to see that when the probe is placed on the mouth, you will have the absence of the collagen peak. You just see NADH there. Next. Okay, so these are some of the malignant spectrums, and it actually, like I mentioned, it's just for somebody to just view. They don't even need super diagnostic skills. You can straight away say, this specimen that I'm seeing definitely is malignant. It is not normal. Next. Okay, so this is giving you the normal spectra from different sites of the mouth. We looked at various sites, and the profiles, if I mentioned, keep looking the same, the NADH and collagen. Next. Yeah, see what happens to leukoplakia and all the pre-malignant conditions. You see totally an abnormal descriptive optical signatures that you see. It's totally abnormal. So that will straight away tell you that something's wrong in the mouth. Okay, so I had to quickly rush to the last 5 minutes. I'm sorry about the glitch initially. I just want to conclude saying it's just so incidental that this month is supposedly the Oral Cancer Awareness Month, and as part of the burgundy and white ribbon that you see there is part of the Oral Cancer Awareness Month, I should say. And thank you all so much for having me here. Thanks again to Dr. Chai David ma'am and Dr. Ramurthy sir, the faculty of oral medicine at Dayananda Sagar, the principal of Dayananda Sagar College, and thanks to all of you. Happy to be here today. Thanks.
Thank you very much, sir, for that wonderful presentation and for giving us so many latest updates on OPMDs. So, due to time constraint, sir, we will not be able to take up all the question. Sir, there is one question in the chat box, sir. Sir, there's a question from Dr. Farzana. Can pre-leukoplakia be given as a diagnosis?
Okay, I was okay. Let me, since a lot of oral medicine faculty are here too, with due apologies and due considerations to everybody. I respect everybody's opinions. I was even talking about the same when I was speaking to the rapid review students too. And unfortunately, in oral medicine, all of us have trained in various dental schools. So each of us have been trained a certain fashion with their own teachers having their own ways of learning. They learned something, they added knowledge, then they came back and told us something. So we started following that school of thought. I would say it's very subjective to say whether what you want to call it pre-leukoplakia. I'm only saying we are actually adding more confusion to this whole process, I would say, giving so many different terminologies. I, for one, would not want to use a term like a pre-leukoplakia because clinically, see, ultimately, leukoplakia is a clinical finding, right? You stretch the mucosa, you have a look, you see a white patch. As long as it's not scrapable, you have a tobacco-related association. You just call it leukoplakia. Don't even bother to go use another term saying it's pre. I'm a little doubtful, I'm a little skeptical whether it's leukoplakia. I would say call it leukoplakia. Nothing one would achieve by calling it a pre-leukoplakia because why? Not just for academic standpoint, but because your treatment is not going to change much. Even if you want to call it pre-oral leukoplakia, I'm going to still use the same tobacco counseling. I'm still going to use the same antioxidants. I'm going to use lycopene. I'm going to use all that. So from an academic standpoint, I would say not have too many of these terminologies. The more terminologies you have, you'll have to again segregate saying where it is fitting. So I'm not too comfortable using the pre-leukoplakia. But again, it's every dental school's thought. Just to conclude and just to add the point, if I'm allowed, since we have so many senior faculty here and the Karnataka State IAOMR, I did have a lot of discussion, if I'm allowed to say, just for 1 minute, with many faculty. I think, ma'am, I mean, Chai David, ma'am, Ramurthy sir, since we have now a wonderful Karnataka State branch, we should. I mean, I'm surprised to see all studies, and we all have been talking many times, see a lot of studies coming off the West talking about diseases of Indian continent, right? Indian subcontinent. We all talk about, they are telling us what is the word leukoplakia, lycanthropus, what is malignant transformation. I think I spoke, I think Dr. Shruti once from EB Shetty, Dr. Vidya there. I think what we should do is the next 4 years or 5 years, we should start to collaborate and get out a lot of data from maybe just Karnataka. I think I spoke with Ashok sir, you see in there once. So I think we should collaborate, each of us giving our own results on leukoplakia, what's happening, what's the etiology, what do we see, how are we treating, is the treatment successful or not. Let us start to record all the data, and maybe 5 years from now, have that big, nice conference on potentially malignant disorders, and each dental school in Karnataka puts up their data. I think we should do something like that. I thought I should just share my mind. Yeah, so thank you all for that opportunity again. And if there are any doubts, I'll be happy. But since there's lack of time, you can share my email ID with anybody who wants it. It's oralmedicine@gmail. Anybody can mail me and I'll be happy to write back.
Sure, sir. Thank you very much. The remaining questions will be answered through mail. I will share sir's email ID also. Thank you very much once again, sir. I now request Dr. Chayam David to give a vote of thanks.
Good evening to one and all. Thank you so much for bearing with us, even though there were some technical problems. We are very grateful to Dr. Ravikiran Ongloe to come and share his knowledge, and I'm sure that has been very intuitive in the sense that we all have a lot to think about in this area. And thank you very much, Dr. Ravikiran, for highlighting so many things and bringing to the fore the knowledge that you have. I'm sure it's helpful for not only the faculty, but the PG students who are just starting off also. Thank you so much. I take this time to thank my management, my principal, and the Karnataka State Branch of IAOMR. Thank you all. I especially want to thank the CDE committee, Dr. Shilpa and her team for taking the trouble to arrange this and making it go on smoothly. I especially have a word of thanks and gratefulness to Dr. Preeti, who is a senior lecturer in my department, for having hosted this, and also Dr. Farzana, a PG student, for helping out. Thank you all, and we'll be having many more such programs. And I request you to suggest what topics you people would be interested in to discuss. So like Dr. Ravikiran was saying, each one of us have developed our knowledge skills in different corners of the country. And we've all learned differently and we teach differently. But there should be some commonality. And I think this is a forum which we can come together for. Thank you all again for attending and all the very best for you. Thank you, Dr. Ravikiran. Thank you once again.